All right, well, why don't we go ahead and get started? I'm Peter Huang. I'm the chief of the Division of Rhinology and Endoscopic Skull Base Surgery. And it's my real pleasure to introduce our speaker tonight. This is sponsored by the Division of Rhinology. Our speaker tonight is Dr. Xiang Chen. And you can imagine there's no greater friend to a rhinologist than somebody who specializes in facial pain and then really is passionate about treating patients with facial pain. So Dr. Chen and I have had a really wonderful collaboration, and he's also a great friend too. Dr. Chen is an associate professor of pain medicine, and he's also co-director of the Stanford Facial Pain Program, which is a really terrific program that a lot of our patients take advantage of. And in addition, Dr. Chen is the medical director of the International Medical Services Office. So for those of you who have an interest in seeing international patients or want to learn more about that pathway, Dr. Chen is a great resource. So it's my pleasure to introduce Dr. Chen, who's going to be speaking tonight on interventional treatments for chronic facial pain, hemifacial spasm, and beyond. Xiang?
Thank you so much. Thank you, Peter, for the wonderful opportunities for the tonight's talk. I have listed my email addresses here. Please feel free to send me messages if you have any further questions. And I work with many colleagues from the ENT department. First, as an anesthesia resident, I did training here from 2008 to 2012, and later specialized in pain. I have been practicing pain medicine at Stanford for the past 9 years or so. I've made a lot of friends here. So again, appreciate this wonderful opportunities. So today I'll give my presentations on how our pain clinic using interventional treatments for various pain conditions, and as well as a new direction of hemifacial spasm. If time allows, I will spend a few more minutes to talk about additional indications that we're currently treating. So I have nothing relevant financial disclosures. There's no off-label disclosure needed here as well. So today's talk will mainly I organize in 3 sections. And in the first section, I will, many of you are experts of the nerves and ganglions on the head and neck. Nevertheless, and I will do a brief review and mainly to correlate them with those various cranial neuralgia conditions that's pain related. Then I will review the common pharmacological interventions at the Stanford Pain. Specifically, I will talk about ketamine infusion and lidocaine infusion that we offer on routine basis for our patient. I would not spend time on talking about other pharmacologies intervention due to time limitation. In the last part, I will introduce our interventions performed at our pain clinic, in particularly the CT guided intervention that I helped develop since 2013. So the first that we'll introduce is the cranial nerve number 5. Many of you are very familiar with this nerve. This is the largest cranial nerve. The sensory root is in the pons and has 3 branches, 1, 2, 3, and basically innervates the skin, mucous membrane, and sinuses of the face. And 3 of them, those nerves, 3 branches, are coming from this ganglion called the Gastelian ganglion. A lot of times we call trigeminal ganglion. It's in the middle brain fossa, and sometimes we call this area as Merker's cave. It's halfly covered by meninges, and they are originating from the trigeminal nucleus, nerve nucleus in the brainstem. The blood vessel compression, which I'm going to mention in a few slides, happens right here at the entry zone. So the 3 branches, they come out from the cranial middle brain fossa into the face through different holes. And I want to spend a few seconds to talk about the biggest branch. The V3 branch comes out through this foramen ovale, which is very big, 5 to 10 millimeters in variable. And right next to it is the small brain, a small foramen is called foramen rotunda, which is round by its name. The V2 nerves comes out from there. And there's a supraorbital fissure where the V1 nerves come out from it, which cannot be viewed from this angle. So trigeminal neuralgia, this is kind of a very old, terms that have been discovered many hundreds of years ago by a French neurologist and termed the tic douloureux. By the name, you can for unbearable pain that humans beings suffer through. Many patients, I have many trigeminal neuralgia patients in my clinic, and many of them will compare this as having a labor. Many times they would say this is even more painful than having a baby without epidural. So the feature is really, it's a brief episodes of very severe, sharp stabbing, lacerating, electric shock type of pain. Electric shock type of pain is kind of the key word. And it's almost always unilateral. If you see someone who has bilateral, facial pain on the V1 or V2 area, usually you wanted to look for some other causes. For example, multiple sclerosis. It could be spontaneous, it could be evoked, and it could have multiple attacks occur over a short period of time. Once you have that kind of a shock, when it's gone, you will have this refractory period. For example, if you brush your teeth or eat the food, you trigger this pain, and then you stop for a couple of seconds, a couple of minutes, pain is gone, then you have this refractory period where you can finish eating, finish brushing your teeth. In general, if you do a neural exam on this patient, they have very normal facial sensations. So the pain could be in various distribution, V1, V2, V3, but for majority of the patient, you would have combinations of either 1, 2, or 1, 2, 3, or 1, 2, 3. So some patients will ask, like, okay, Dr. Chen, I have this trigeminal neuralgia. Will it ever get better? The question is, I don't know. There's really very few studies examining the natural history of the trigeminal neuralgia. It may get worse, it may get better. Sometimes it will just go into complete remission that will last months or years. It's really unpredictable. Then this makes the clinical kind of a treatment plan is really challenging sometimes. It just goes away by itself. But for majority of patients, it will not. So what caused trigeminal neuralgia? The current dominant theory is still the compression theory. So we think that there's a blood vessels touching the having a mass effect on the nerve when access the brainstem pons. However, there are many patients who have incidental findings of vascular compression on the nerve, and they don't have pain. In fact, I have a patient today from LA who have bilateral vascular compression shown on the MRI, but she only has the right side trigeminal neuralgia. So that the UCLA surgeon said, oh, well, I can't really do the microvascular decompression surgery for you because you have compressions on both sides, but you only have pain on one side. I'm not sure the vascular compression is the cause of the pain. But nevertheless, the dominant theory at this time, it is still the vascular compression theory. It could be artery, it could be vein, it could be others, but majority of them are arteries. So how often do you see trigeminal neuralgia? We used to think there's roughly about 13 to 50,000 new cases a year in America. However, recent studies really showing that the incidence is significantly higher based on some of the epidemiology studies in European countries. We now think that there's about 40 to 80,000 cases a year, new cases. So the female tend to be a lot higher incidence and usually happens to people who are 50 or older. And sometimes they could be associated with other cranial neuralgia. Most notably is the glossopharyngeal neuralgia. Whether it's genetically inherited, it is, or it's really not, most of the people think it's not. There's very occasionally it's a familial occurrences, but in general, it's not. So the definition, used to be really confused. As an ENT docs, and you oftentimes we hear atypical facial pain, trigeminal neuralgia, and neuropathy is really difficult. But the ICHD in 2013 has really made it simpler for us, that they put trigeminal neuralgia into two groups. The one group is you have vascular compression as a cause, and the other group, you have the causes other than vascular compression. So as long as you can identify the cause, you can put them into painful trigeminal neuropathy group, versus the other group is the classic trigeminal neuralgia. The pain could be intermittent, purely paroxysmal, or you could have concomitant persistent facial pain between the episodes. But you both of the subtypes, you call them now classic trigeminal neuralgia. So when you do examinations on painful trigeminal neuropathy, oftentimes you will find out that their corresponding dermatomes will have less sensitive to touch or to pinprick. If it's hyperalgesic, meaning that if they're more sensitive to painful stimuli, that's usually non-specific. We don't take that, too much of we take this with a grain of salt. So again, painful trigeminal neuropathy, that it is the one that is caused by lesions that you can identify, and it's other than vascular compressions. In your practice, most of the time you would probably see the patient who have multiple sinus surgery or trauma to your face, and then they started to develop this neuropathy. So again, I mentioned atypical facial pain. I want us to spend one slide here. So what exactly is atypical facial pain? You would also hear this term as idiopathic facial pain, persistent idiopathic facial pain, PIFP. So the incidence of atypical facial pain or PIFP is much higher than trigeminal neuralgia. People estimate that up to 26% of general population will suffer from this pain at some point in their life. So the unique feature is it is unlike the trigeminal neuralgia. The pain is very poorly localized. It does not follow the trigeminal division dermatome distribution, and it is persistent for all or most of them or most of the day rather than intermittent. And the feature, the quality of the pain is rather than electric shock. They would oftentimes describe to you as a burning sensations, or they say it's really an achy, crushing, or severe kind of a pain. So the feature of the pain is different. The pattern of the pain is different, as well as the underlying etiology is different. So it includes a wide spectrum of disorders, including TMJ, facial pain, burning mouth syndrome, and post head and neck surgery, persistent pain, etc. In terms of underlying etiologies, we believe that it is a combination of both biological factors as well as psychological factors. So though you got those two, and that's why those patients are very difficult to treat and to manage. They're different than the spectrums of trigeminal neuralgia. So we talked about glossopharyngeal nerve. Now let's move on to cranial nerve 9, right? Cranial nerve 9, they have the sensory inputs from oropharynx, carotid body, and sinus, and as well as posterior tongue, middle ear, and the eustachian tube. And they have some sympathetic and parasympathetic innervation to the gland as well, and originates in the medulla, a little bit coarse laterally to the posterior cranial fossa rather than the middle brain fossa for trigeminal nerve. And then they come out from the brain through the jugular foramens right here, okay? So they have the superior and inferior ganglion versus gasseting ganglion for trigeminal nerve. They come out from this jugular foramen. So the dominant theories of glossopharyngeal neuralgia is also due to vascular compression. As you can see here, there's a steroid process here, and then there's, once it comes out from the brain, it will cross through the neck and pass behind the steroid process and then reach to their target. So the pain distribution is also different. So they're in the angle of the jaw and the ear and tonsil pillar and then the tongue base as well. It's very, very painful. The quality, severity is similar to trigeminal nerve. So a lot of times they misdiagnose with trigeminal nerve because both of them are so similar. Swallow, talking, sometimes brushing teeth as well. And then it would just happen. Fortunately, the incidence is relatively rare. So just remember, every 5 trigeminal neuralgia, you probably will get 1 glossopharyngeal. Okay, so the next nerves and ganglions on the head is my favorite, and it's the sphenopalatine ganglion. And sphenopalatine ganglion neuron, it's extracranial, right? So it's a nerve bundle behind the bony structure of the nose. This is the one that you are very familiar with, and you're dealing with this all the time, not routine practice. It is very closely associated with trigeminal nerve. You may have heard a term called TAF, a trigeminal autonomic reflex. This sphenopalatine ganglion is the one that's responsible for it. In terms of location, it is behind posterior to middle nasal terminate in the maxillary sinus within the pterygopalatine fossa. Sometimes we call it as pterygopalatine ganglion as well. The reason I said this is my favorite because it's so complex. It receives both sensory, parasympathetic, and sympathetic inputs. sensory from trigeminal nerve, parasympathetic from facial nerve, and sympathetics from superior cervical ganglions and carotid plexus. And it inputs to all the glands on the face through the facial nerve, and the afferent sensory fibers. They're from the nasal cavity, soft palate, pharynx, and etc. And they put their, they project to the Gestalt ganglion through the maxillary V2 nerve. One other thing I want to mention is that this ganglion is very, very closely involved in the innervation brain vascularization. It is involved in migraine, cluster headache, Schroeder's neuralgia, vascular headache, and atypical facial pain. So if you take a close look, this is where it is. And as you can see, it received the sensory input from maxillary V2 nerve and receives the parasympathetics from the facial nerve through geniculate ganglion, and also received the sympathetics from the superior cervical ganglion. And if there is some neuralgia too, and this is the one that from your literature is the Schroeder neuralgia, right? So it's kind of a unilateral, moderate, severe, burning, boring, nagging headache. Usually it's around the eye or the root on the lateral side of the nose, and radiating to the maxillary regions and associated with teeth, sarcoma, mastoid area, occipital, sometimes go down to the shoulder and an arm. It could be episodic or it could be continuous. It's just not very specific. And if you're trying to look for the causes, then yeah, maybe there's some infections going on there, maybe some chronic sinusitis. They may have multiple surgery, trauma, and etc. And occasionally you may find some content points, right? This is contact points, headache used to call, and then etc. And then you run into this definition is a cluster headache. The cluster headache happens usually to the young people. Usually happens at early in the morning, and they wake up from a severe, terrible kind of knife going through head, that type of pain, lasting from 15 minutes to 3 hours, and with most importantly, they're combining with this kind of autonomic symptoms with tearing, nasal congestions, and nasal discharge, edema, and then sweating, meiosis or ptosis, this kind of thing. So nowadays we think that both Schroeder's neuralgia and cluster headache, they're like about the same thing. They're all, belong to this trigeminal autonomic cephalgia kind of a territory. Is the main distinguished factor is that the cluster time tend to kind of you have this happens, in the cluster time, usually this kind of trend find only for cluster headache, while the area of the pain more at the level of the nose, that's the case for Schroeder's neuralgia. But they're the same thing. The problem, underlying problem, is the sphenopalatine ganglion. Let's move the gear a little bit to the facial nerve now, to facial nerve. So this is kind of a new territory I'm going into is the facial nerve. Facial nerve obviously has both sensory and a motor, right? So the motor nerve is a big component, is the facial expression, right? And then the nerves comes from the pons, right? And then they form a geniculate ganglion and greater protrudous nerve, and then make a contact to the V2 trigeminal nerve that's responsible, for its sensory. And then the motor nerves that comes out from the steroid mastoid foramen and innervate the face. So the sensory ganglion, of course, is the geniculate ganglion. It's between it's right here. It's between the cochlear and the tympanic cavity, a little bit anterior to the semicircular canals. So it has the cell bodies conducting taste sensation, as well as the sensations innervating the palate, pin of the ear, inner canal, eardrum, and etc. So when these nerves have trouble, you got this called nervous intermediate neuralgia, right? Sometimes we also call geniculate neuralgia, or sometimes, it's called Ramsay-Hunter syndrome. And basically it's a nerve disorder affecting geniculate ganglion. So patients, the unique feature is they feel this kind of a sharp electric shock type pain, intermittent, deep in their ears, in the artery canal. You do have nerve exams, not really, there's not much of findings, but the pain is deep into the ears, and they said it was like ice pick, go into the ears. Very, very, very painful. So this is this condition. But when the motor nerves are having problem, then you got into this hemifacial spasm territory. So the patient would have this intermittent twitching of the muscles, usually begin mainly in the orbicularis oculi muscles, and for 90% of the time, just a very brief, intermittent, repetitive contraction, it could lead to a sudden involuntary eye closure. Some of the patients who present to me is really, they can't really see. And typically associated with elevation of this eyebrow, the other name is called the other Babinski sign, right? It's kind of like the big toes. And it could be persistent during sleep, cannot alleviate that. Sometimes they feel this paroxysmal clicking sound in the ear, the stapedius muscles got infected, and later they can progress to the entire face. So it's not painful. It's not really a painful condition, but the embarrassment, the benign illness, and the social withdrawal is just very, very difficult to bear for our patients. The prevalence also is more in the female and begins in 5th to 6th decades. And bilateral, again, is very rare. So the dominant theory, again, is very similar to the other cranial nerve, trigeminal or glossopharyngeal. We think the vascular compression is the bigger problem. But of course, there are other causes of hemifacial spasm as well as the secondary ones from tumor or from AV malformation or for brainstem lesion or infections or Bell's palsy, a viral infections, and have some issues with the nerve paralysis to start with. When they recover and put them at risk for spasms. So with that being said, so those are in general, the cranial nerve and neuralgia that I oftentimes run into in my clinic, in our pain clinic. The hemifacial spasm is relatively new, but others are not new. We've been dealing with it for the last 2 decades or so in our clinic. So once we learn about their clinical features, we give them a definitive diagnosis, we give them a differential diagnosis, and the first line treatment is oftentimes medical management. And this is how we treat our patient. It's a multi-model treatment, right? So the first line is the pharmacotherapy. I don't have time for the opioids and non-opioids adjuvants today, but I will spend a few minutes to talk about lidocaine infusion and ketamine infusion, which you as a surgeons probably have already, very familiar with. When I'm on acute pain, the acute pain service will provide those 2 infusions for your challenging patients who suffer severe pain after surgery. So the first one is lidocaine infusion. Lidocaine infusion is really not only it's a sodium channel blocker, but also has anti-inflammatory features. We know that some of the damaged nerve will develop abnormal, spontaneous active sodium channel site of injury. They could sensitize your brain neurons, such that lidocaine infusion could help relieving the mechanical allodynia and hypoalgesia associated with this chronic neuropathic pain. And we don't see, and it can be given multiple times. So we oftentimes will admit those patients for 5 days in the hospital to provide this for them. And we have a lot of meta-analysis data to confirm the efficacies for perioperative management, for complex regional pain syndrome, etc., major spine procedures. However, the data on chronic facial pain is still limited. There are some studies to show that the trigeminal neuralgia, could be helpful, and the red line is the placebo. As you can see, the blue line is lidocaine infusions that could last beyond the infusion. So you stop the infusion, the benefits could continue. And this is for various nerve injuries, many years ago, and you can see that the lidocaine infusion can provide significant amount of relief for our patient, and those patients, including trigeminal neuralgia patient. As you can see, 6 neuralgia patient, you got 5 of excellent relief and 1 with partial relief. The problem is how sustainable it is. And there's also a phase 2 pilot study to evaluate for opioid refractory pain in cancer patient that suffered head and neck patients. And we have found out very good relief that's sustainable. So in general, this is how we do in the clinic. If you have a patient in your practice, you have this facial pain that's refractory to your surgery, to medical management, or temporarily they don't want to have any intervention, you could refer this patient to us for lidocaine infusion. This is typically how we do it. We will have this patient admitted to the hospital in minimums, a day, and it could be a 5 days courses. Likely helpful in facial pain, but RCTs are randomized control studies are further needed. The next one is the ketamine infusions. Ketamine infusion is very interesting. It is a non-competitive NMDA receptor antagonist, and we all know NMDA receptors very clearly involved in the development of central sensitization, opioid tolerance, and chronic pain. Ketamine, over the many years, we have found out that in the close monitoring situations, if you provide continuous infusion, it has a very powerful anti-hyperalgesic effects and to reduce or reverse the opioid tolerance. And of course, recently people also found out that ketamine has a great benefit of relieving some of the major depression and suicidal ideations. And of course, it may help for psychiatric components of facial pain as well. And we offer this infusions on a routine basis for our chronic pain patient as well. However, for intractable facial pain, there's really no true RCTs yet. There's some data that the recent 2019, there's a randomized, there's a meta-analysis, a systematic review, and found out that they identified a 7 studies meet the inclusion criteria, and then 3 out of 7 studies they have found out significant analgesia benefit favoring the ketamine. This is very encouraged to us. And then in 2020, we have conducted, I have led a study, retrospective studies, and we have reviewed the studies. And indeed, this is consistent to the findings that 75% of people with trigeminal neuralgia or trigeminal neuropathy, they responded well with to ketamine infusion. They have good short-term and long-term relief. 2 of the patients actually had more than 6 months relief after one time infusion. Keep in mind, those are the patients who have failed almost everything else when they come to us for the same infusion. So ketamine infusion could be effective in refractory facial pain syndrome, but again, this is a retrospective study. This is a very small power. So we have to do a lot more cases and increase its power. We also have to do true randomized control studies, which is underway. So this is kind of our infusion guideline in case you're interested. All right, so now let me go to the last part of my talk today is the head and neck interventions that we do in our clinic for facial pain and hemifacial spasms. I will present this 5 type of procedures: the Gacillion ganglion radiofrequency, Gacillion ganglion RFA, balloon compression, and glycerin urolithosis. A new type of rhizotomy we developed at Stanford to treat V2 trigeminal neuralgia, and also glossopharyngeal neuralgia nerve rhizotomy at the steroid process. This is relatively new as well. And most recently, we have developed this steroid foramen level of facial nerve awake rhizotomy to treat hemifacial spasm. And last, in collaboration with Dr. Huang, we have started endoscopic guided sphenopalatine ganglion at intranasal SPG foramen to treat various headache patients as well. So Dr. Hattel, more than 100 years ago, have developed this technology. It is that back then there's no imaging guidance. He was a neurosurgeon, a very brave one. He saw those patients and he was wondering, whether we can help treat them without open craniotomy. And this is how he developed this classic transforaminal foramen ovale Hattel technology. Is you have a needle going through the foramen ovale to target the extending ganglion, and you deliver thermal energies to ablate the nerve. This is how we do it. You have a patient in the operating room, and in the submental view under X-ray, this is one of my patients, and you can see with the red arrow, there's this kind of like a football oval, hole. This is foramen ovale. And then you, at the corner of the mouth, 2 centimeters away, that's Dr. Hattel's landmark. And you go in and with your needle go through the foramen and you go into the the middle brain foci in the Merker's cave, then you can deliver thermal energies to kill it. Depends on which division they have, V1, V2, V3, you can turn the electrode around. You do the testing, and then patient tells, oh yes, this is the area that's tingling, and this is the area I hurt. Then you deliver thermal ablation at 80 degrees of Celsius, and then to ablate. Sometimes with this kind of ablation, people start to, the nerve ablation is pretty profound. They will complain, they will complicate it with profound numbness, right? Some people don't like that numbness. And the V3 also has some motor components that they will have some motor weakness as well. And over time, people have used glycerol, which is a neurolysis agent, but it's less potent, less invasive than alcohol. So with the needle go into the cranial ganglion, we'll inject about 0.4 cc's glycerol to slowly kind of have a demyelinating kind of lesion, creating lesions there. And you can also 60, 70, 80% of 60 to 80% of time, you can ablate the ganglion, but the weakness or numbness tend to be less. I routinely offer this procedure to our patients as well. Or you could use a balloon. So using a balloon to inflate the balloon using mechanical pressure to compress on the ganglion and then to kind of destroy the nerve, destroy the ganglion. That is also donable. They all have various technical advantage over each other, and with different patients, you would choose, different techniques for them. But we do all three of them here. So the advantage is very widely used. It's very easy to do. It's the same day procedures, right? It's a percutaneous and minimal invasive. The needle, once you pass, then you apply the lesion. Success rate for the first year is more than 90% for pain relief. And for 5 years, the recurrence is about 20%. So it's really good. So the disadvantage, of course, technically very challenged if you have a patient who only have one branch neuralgia, for example, a V2 trigeminal neuralgia, then you really cannot distinguish that much between V1, V2, V3. So you have to position your needle at the multiple attempts. And it's painful, patient's awake, right? It's really one of those most cruel procedures that you do that, train as an anesthesiologist, this is every moment to me is like an hour long. Of course, as you prolong the individual branches, you increase the chance of a dural puncture, leak, and infection, bleeding as well. And after a while, patient give up and you give up, and then you just say, okay, let's just do it. And you really don't have the ideal position for the needle tip in the Merker's cave. So I took that problem about 8 years ago, and I went into the cadaver lab. I collected a couple skull, and then I was like, okay, is it possible that we only target the the V2 only, for example? And because the V2 nerve comes out from the foramen rotundum, and I was able to find out, yeah, this is possible. And then I built up the CT imaging database, and it's possible that you can visualize the foramen rotundum. You can actually have a needle goes in, just edging the maxillary sinus and get into it. And then we enrolled about 27 patients. They all have isolated V2 trigeminal neuralgia. We separate them into two groups. And one group using the conventional approach to isolate the V2 branch, and the other group just going to the foramen rotundum, and we're able to get it down. And for example, this is one of our patients. Remember now, the needle entry point is a little bit different. The Dr. Hatau's technology for the foramen ovale is at the corner of the mouth, 2 centimeters corner of the mouth. But in this new technology, we're actually, the entry point is at the base of the nose and cross point of the outside border of the eye. This is where we're going. You can see the needle goes into foramen rotundum, and you deliver the ablation. And this is one of the representative patients. Both of them have V2 trigeminal neuralgia. We ablated. For this patient postoperatively, the numbness is only in the V2 area. But unfortunately for this patient, even though we were targeting the V2 branches, after the ablation, he reported numbness in the V3 area as well. So we show that the foramen rotundum is donable, and it has very good clinical outcome. very, with less complication and much shorter procedure time. So with that, we furthered these technologies in the CAS Lab 9 and 300p, and now is in Hybrid Room 27. We were able to do that. And we published first in 2014, and later we published in 2017. So we also do the balloon compression. So you ask, why do you do balloon compression? The balloon compression is because again, some of the patients, they really don't like the numbness from the interventions, and they wanted to have an intervention that can give them less of numbness or less of kind of a weakness. So basically, they want to have kind of a graded or titrated ablation of the nerve. And then I started to work on the balloon compression, because one is, the mechanical pressure to the balloon, you actually can control, right? So, gradually increase the mechanical pressure. Two is that I could, titrate to the patient's response, and I was able to do so. And then we just recently finished the study. We also found out that the shape of, the balloon is important, which is consistent to a previous study. And we recently published the studies in July past months that were able to do awake CT-guided percutaneous balloon compression and had good results from it. Okay, so now we're going to move gears to the glossopharyngeal nerve block. So conventionally is that, you do X-ray at the base of skull, and then you try to find the steroid process, and then you hit the steroid process, and then you move the needle behind the steroid process, and then you do electrostimulation and you confirm the glossopharyngeal nerve, and then you do the ablation. However, it's incredibly difficult to do this on the furrow. The steroid process, unless you have Eagle syndrome, the steroid process is very small and it's very difficult to see. And there's a carotid arteries right next to it. There's a vagus nerve. There's very, very much vascular rich area. And then if your needle just go a little bit too much, and then you gotta get a vascular puncture. So we have developed a CT-guided technologies here. We're providing to the patient on routine basis now. And we made this challenging block to be a very straightforward one. As you can see, this is one our patient, the base of skull, because the steroid process very clearly. And under the CT, we can, push the needles in, we hit the steroid process first and move behind it. And then you turn the electrostimulation and you confirm the location. You confirm it's on the glossopharyngeal nerve. They tell you, oh yeah, it's my throat, it's start to tingle, my ear canal start to tingle. Then you know you're on it, and then you deliver rhizotomy, and then to ablate this nerve. We published this articles in 2018. So the facial nerve is something that I'm really excited about this. The reason is that, as I introduced in the previous slides, the hemifacial spasm treatment, the dominant treatment is vascular compression, vascular decompression surgery, if you have a vascular compression on the nerve. But there's a significant amount of patients, they don't have vascular compression. So what are you going to do for those patients? And then the other treatment that's available has very good data, very good results, is Botox injections, right? So Botox is the main, non-surgical treatment for hemifacial spasm patient. However, it requires repetitive injection, and over time, you tend to lose its efficacy. And also Botox injections, sometimes, it's not very experienced hand will cause aphasia asymmetry, muscles, atrophy, etc. Every 3 months you have to repeat it. It's just not the most suitable treatment for every patient. And then the medical management for those patients is not that good. They usually don't respond very well. So with my experience, our experience with trigeminal nerve, glossopharyngeal nerve, etc., we started to think about whether a similar type of, intervention could be tried on facial nerve. Of course, facial nerve is different. Facial nerve, it's a motor nerve. Anything that ablating the nerve is going to cause significant amount of the facial paralysis, which is something that we wanted to avoid. So first of all, we established the fact that under the CT, we could identify, localize the facial nerve at the styromastoid foramen, which as you can see, it's pretty easy to get it done. And second of all is that whether a partial lesion, for example, awake, rhizotomy of the partial nerves, just enough to stop the spasm, but not enough to cause paralysis or permanent paralysis. Is that possible? So we started to enroll a patient and we're able to finish the study in 2 years, enrolled about 56 patients. We found out that if you do graded ablation, 60 degrees Celsius for 30 seconds, another 30 seconds, intraoperatively, you have patient kind of bulging up their cheeks and you're trying to kind of push that away. And then just as soon as you cannot do that, the patient cannot against you, to push against their bulging up your cheek, then you know that, okay, you caused the facial paralysis partially now, and then you stop. And we saw that for 90% of the patient, 95% of the patient, we follow up for 20 months, sorry, the spasms are gone. Their paralysis is very mild. They do have paralysis, but most of them resolve within 1 month. So I know that our ENT colleagues, we have a facial nerve centers here, and I really look forward to working together with you all, that if you have patients who are suffering from facial nerve spasms, that hemifacial spasms, that have failed the Botox injections or medical management, or they're not candidate for microvascular compression, and we're very happy to participate. So we're the only program in the world, in America, in the USA right now, is doing this type of block. And obviously we need a lot of help from you, because right now we only have 50 plus patients. We don't have enough. So we recently published this article in the Journal of Neurosurgery with peer review. So last block I wanted to kind of introduce is the really exciting Sphenopalatine block that's in collaborations with Dr. Huang in your department. So, obviously we have lots of migraine patients, headache patients, atypical facial pain patients, classic headache patients in our clinic. And those patients, once we confirm diagnosis, we offer the Sphenopalatine ganglion block for them. So typically we will do the SPG, the Sphenopalatine block, via either transnasal, kind of like in a Q-tip, or a little bit more fancy device called TX360. Just basically it's a plastic a plastic kind of a syringe with elongated tip, plastic tip, and then you showering, the middle turbinate, and hopefully you block it. And Sphenocast, which is kind of you go into the up turbinate and you shower down, and they have like really unpredictable efficacies. And then we also sometimes go through inside the mouth through the greater palatine foramen, just like when you do fast surgeries and you go, after anesthesiologist intubate the patient, you go to the side using blade and push the tongue away, and you inject through this greater palatine foramen, and you numb up the SPG. That could be very helpful for a day, for the duration of surgery. Sometimes will even extend beyond the surgery. And other times we do percutaneously, transcutaneously with a needle going through the face, going to the sphenopalatine fossa, and you block the sphenopalatine foramen and sphenopalatine ganglion. So this is very aggressive, right? And you have to be in OR, and it's really uncomfortable. So Dr. Huang and I, we started to talk about this, and then obviously he sent a lot of patients to me, and then I also sent my patient to him. And the other time I saw how he practiced with a scope going to the nose, and I thought, okay, maybe we can use your endoscope skill, and then we can have a more precise block at the sphenopalatine foramen, which we did. As you can see from this videos, and this is kind of like a syringe, going through the nostril, and we saw the middle turbinate. As you can see, this is one of our TX360 device. If without the, if without the endoscope, I have no idea. Actually, I'm on the right side of turbinate. This is, I insert it as I usually do. Under a microscope, endoscope, I know I'm on the right side. So now I'm on the correct side of the turbinate, and then you go in, and you see where the foramen, sphenopalatine foramen is, and then you spread the locals right there. You can see this is very, very precise, and patient do consistently better, after this block. And we recently submitted, IRB together. We're doing a using a longer acting local anesthetics rather than the regular lidocaine that blocking the SPG here. We're hoping that the longer you block the SPG, kind of like mimicking the ablation, right? Rhizotomy for 3 days, and you're hoping to see a longer duration of headache relief. Some of the earlier pilot patient consistently showing this is the case. So I'm very excited, and I incredibly grateful to have opportunity to work with someone like Dr. Huang. So those are the reference, and this is going to wrap up my talk today. And obviously, I've gone through many slides without going into details, and apologize if I have created any confusions. But you have my emails, and you can send me emails anytime. So it is really a great honor to have opportunity to work with our, ENT divisions, one of the best in the country. So I wanted to just spend additional 1 minute here that's telling you what we offer in our Stanford Pain Management Centers. When people talk about pain medicine, a lot of time they think that we will be prescribing opioids for our patient, but that's completely not the case. We have about 200 medications that we normally use for our pain patient, and there's only 20 of them are the opioids. And we treat over 800 chronic pain conditions. And our approach is really, it's a multimodal approach. When we have a patient referred to us, we will offer them combinations of medical management interventions, but more importantly, we also encourage them to do, psychology copings, physical therapies, and we also have self-empower mechanisms implemented in our clinic, and we offer a complementary kind of alternative therapy as well. We also have Acquire, which is our patient, outcome reported platform where patients could fill out the questionnaires, and then those questionnaires will, geared towards the physicians and create a very kind of a direct and efficient communication channels. And orofacial pain is a big component of our clinic. And the facial pain program, Dr. Barat and I, we founded in 2018, really got incredible support from many colleagues across many subspecialties in the campus that including your ENT department. So I really, on behalf of our pain division, I really look forward to deepen our collaborations. And if you have any patients that you wanted to send to our clinic, I'll be very happy to take a look. And I will be happy to kind of expedite the appointment as well and introduce you to my other colleagues in our clinic who, take care of facial pain patients. So without further ado, then I am open to any questions you might have.
A question, where does this correlate with migraines?
Yes, Dr. Bowden. So, the migraine patients really is very closely related to a couple nerves on our face. Number one is the supraorbital nerves from the V1 branch of trigeminal nerve. That in fact, many times we target the supraorbital nerve via like TENS unit, like cephaly, or like Botox injection, or just nerve block that can help a lot of migraine patients. The greater occipital nerve on the back is also a big component of it. But more importantly, as I mentioned earlier, is the sphenopalatine ganglion. The sphenopalatine ganglion is deeply involved the vascularizations of the brain in a way. Migraine, right? When migraine really happens is misregulations of our kind of a cerebral vascularization response to painful stimuli. When you have a headache, your vasodilates, blood goes to your brain, you have abnormal filing of the neurons, you got this headache associated with autonomic symptom, nausea, vomiting, sensitivity to lights and sound, etc. Sometimes we take caffeine that can help. Caffeine is very helpful for migraine sometimes, right? Caffeine is a vasoconstrictor for our cerebral vasculatures. A lot of medication developed over time, triptans, right? They work on the same target, is the cerebral vasculature. Most recently is a CGRP antagonist. CGRP antagonist is believed to be released by the trigeminal nerve terminals during migraine headache attack. The antagonist can antagonize that process, cause vasoconstriction as well. So therefore, many of those cranial nerves, in particular, trigeminal nerve and sphenopalatine ganglions are very, very closely related to the migraine pathology and their clinical manifestations. By targeting those nerves, you can help a lot of migraine patients.
Thank you.
Oh, you're welcome.
Hi, Dr. Chan. I have a question. I'm Michael Chang, one of the rhinology fellows. Thank you for a great talk. That was so informative. I think sometimes we see patients in the rhinology clinic that initially present to us with chronic sinusitis, and then we treat it, and then they have persistent facial pain, even after it looks like we've sort of cleared all their disease by all of our clinical metrics. So I'm kind of wondering what the relationship is, what you think it is between sinusitis and something like trigeminal neuralgia. Is that an accepted etiology? And how is inflammation playing a part in this? And how aggressively should we be trying to limit the inflammation, either with surgical or medical therapies?
Yeah, I mean, well, thank you. First of all, thank you so much. This is really a great clinical question, because we oftentimes, got into this scenario is patient coming in complaining pain in the maxillary cheek area, and then you put the scope in, they come in to see you, and you saw some sinusitis going on there, and then you start to treat, but then their pain is not getting better. It makes you wonder whether the inflammation is the cause of the pain, or there's simply just coincidence. This is often there's often the similar situations in the dental office as well, is that, a lot of trigeminal neuralgia patients, they presented first with tooth pain, and they go to the dentist and they start to drill on it. There's some cavities, maybe there's some root canal. I have a patient who actually is extreme cases. He had all his teeth pulled out, entire up jaw, it's all out. And you still have pain, and the dentist said, okay, well, this is probably not the dental problem, it's a trigeminal neuralgia, and refer the patient to me. So I would say very similar. If it doesn't look like a sinusitis, you treat what you can, but if the pain is not getting better, you probably wanted to get at least opinion from the pain physicians, who is specialized in facial pain. Have them take a look. Maybe there's underlying not only just biological components to it. Maybe there's some psychological components to it. Maybe this patient is extremely anxious, a person. Maybe this is atypical facial pain, and the features does not correlating with the sinusitis. I would say it's really hard to have an answer for this question. But my feeling is that, don't exhaust your surgical option for those patients before you send this patient for a second opinion from the pain colleague. Same thing with me. If I have some patients who come in with maxillary pain and I do imaging and I find out that they have some sinusitis, I'll refer them to my surgical colleagues. In this case, it would be Dr. Huang, and take a look. Maybe I'm missing something here, structurally that could be fixed. And then I will co-treat together with this patient.
Great, thank you.
You're welcome.
Sean, thanks for that great talk. I have one more pragmatic question, kind of related to some of the conversation already. And that is, a lot of our patients that we see have, I think, incompletely treated headache, and yet they also have elements that sound like like facial pain.
Mhm.
I'm always sort of trying to debate when I should send somebody to the headache clinic versus the facial pain clinic.
Wow.
And what are some guidelines that we can, follow to make sure that we get the appropriate consultations?
You might got me into trouble. It's a great question as well, is that historically, the headache clinic exists before the facial pain program. So the idea is that, we see some of the pain patient, the headache patients may benefit from interventions and psychology counseling, while the neurology department, they don't have that, right? So they don't have those tools for some of the interventions that we just talked about, nor they have, a strong existence of psychology coping, etc. So they send this patient kind of like, they set up a headache clinic in our division led by Dr. Cohen. But then we realized that, it's much more broader, not just headache patient, but many of those facial pain patient, atypical facial patient, they need a special, specialized group to treat them together. Surgeons, psychologists and neurologists, pain and ENT, dentists, and etc. Then 2018, the facial pain program started to kind of kick in. I would say that we also have Merida, who's a neurologist, and Dr. Broad is a neurologist specialized in headache, but she's also the co-director of facial pain program. She and I. So I would say, to be honest, I would say that if you have someone who has a facial pain but also a headache, it would be very appropriate you send to this facial pain clinic to have initial evaluations. And if we feel like, the headache is better managed by our headache colleagues, we'll send this patient usually to Merida Broad. And Merida, if she can't accommodate, then she will give this to her neurologist colleagues. And if it's more towards interventional, and then I will be jumping, and a few of my colleagues also do that, Agwan and myself, and we're all, the interventionists who specialize in facial pain treatment. Does that answer the question?
Yeah.
Yeah. Okay.
I actually have a pretty similar question. Suchan Agwal, I'm one of the general otolaryngologists. You mentioned about the facial pain program. There seem to be two separate programs, one by, that includes Mary Barad, but also there's Michelle Johansson.
Yes.
And I'm not sure what the relationship between the two are, and who should go to which group. How do we resolve that?
Okay, I haven't done a good job then. Michelle Johansson is part of our team members. She's a community physician who is specialized in TMJ, dysfunction, and she spends about 4 to 8 days per month in our facial pain clinic at the Redwood City. So she doesn't do any procedures, but she's the dentist / TMJ specialist, conservative management. She's part of this facial pain program.
Okay, so she is.
Yes, she is. Yes. And if there's any confusion, I'll be very happy. I answer my emails almost on daily. So just shoot me an email and I'll be happy to take a look and help expedite the referral.
Okay, because usually in the referral, when you enter the referral, there are options to choose general pain, neural pain, or there's maxillofacial. There's a whole bunch of different options.
Really? Okay.
So yeah, so if we pick maxillofacial pain, we'll sort of get to the right person depending on what the problem is.
Yeah, so as long as you specify like it is a facial pain, I think our coordinators knows that the patient will flow to our group of physicians.
Okay, thanks.
You're welcome.
All right, I think that wraps it up for us. Thank you, Dr. Chen, for an outstanding presentation, and everybody have a great evening.
Thank you so much.
Thanks.
Have a wonderful evening. Bye-bye.